Good morning, everyone, and thank you for joining. Thank you to New World Medical for the invitation to speak and for Dr. Netlin for moderating this morning. I'm going to be talking to you about the results with the Kahook dual blade. These are my financial disclosures. So we're fortunate enough to be practicing in a time where we have a number of different options to bypass trabecular meshwork. If this is the site of greatest resistance to aqueous outflow, we want to get past this tissue to reestablish a physiologic outflow, and the Kahook dual blade is the newest method for doing that. For those of you unfamiliar, the KDB is a precision device engineered specifically for the angle anatomy. It incises the trabecular meshwork through two paired incisions that allow for not only incision but excision of that tissue as well. It's all done through an ab interno approach. It's easily paired at the time of cataract surgery through your clear corneal incision. A couple of advantages of it are that there's no implant left behind, there's no hardware left in the eye, there's no additional equipment required to perform the procedure. It's a single-use disposable ophthalmic knife. There's four key design features I want to point out. First, the sharp tip of the device, which is designed to pierce across trabecular meshwork. Then the ramp downstream of that serves to elevate and put that tissue on stretch, which is really like wet tissue paper. And by putting that on a gentle stretch, the dual blades can do what they're designed to do, and that's to create two parallel incisions along the trabecular meshwork to typically result in a free strip of meshwork that you can remove from the eye. And then the foot plate or heel of the device, which is designed to fit atraumatically within that canalish slim so that as you are advancing the blade in the angle, you're not causing collateral damage. And this is just an animation. If we could start the video here. Just demonstrating those features of the blade. First, that tip, which will pierce across trabecular meshwork, then the ramp, which gently lifts and puts that tissue on stretch, and then the dual blades, which create those two paired incisions, which allow you to excise a strip once you complete. So after you pass from one direction, you reverse the blade in the eye and carry that blade back towards your initial incision, and this usually results in a free strip of trabecular meshwork, and you can see the cleft that's resulted of that. And then here's some video in real time here. This is a case really from start to finish. Can we start the video, please? So you can see it fitting through. This is a 1.5 millimeter incision. Really want to mag up on these cases. With any angle surgery, visualization is key, identifying the landmarks you want to treat. The way I perform it now is placing the blade to the far right of my view and applying gentle pressure to allow that blade to pierce across trabecular meshwork. You'll see the tip disappear right there as it goes behind that pigmented tissue. And then carry that blade gliding within the canal as far as you can in one direction. And you can see the resultant cleft left behind the blade as that trabecular meshwork is being excised. Once you carry it in one direction, then you reverse the blade within the eye, start to the far left of your view, and carry that blade within the angle back until those two incisions meet. And this usually will result in a free strip of trabecular meshwork. And you can see after the completion, you've got reflux of blood from a few collector channels there that we've now unroofed. And then after the case, if you focus on that nasal episcleral veins, you can see a nice blanching after the procedure, which is a good indication of patency of those distal outflow pathways. If you're left with a strip of tissue that's tethered to the angle, you can go in with duet forceps, as in here, or micro forceps to retrieve that from the angle, or with INA. What's unique about this blade is that because we're not only incising, we're excising this tissue, you can actually remove this and you can see what you've done, which is pretty cool. And this is what they look like. These are all post-op KDB gonio photos. You can see the nice cleft that can be created, highlighted here by the arrows. So you're seeing this white band, which is where trabecular meshwork has been removed, and we're looking directly into that back wall of Schlemm's canal. Can we start the video here? This is just a video gonioscopy showing you the extent of a cleft that could be created as I rotate. This is with a Goldmann lens. You can see how far this cleft goes, almost 5 clock hours in this particular patient. And this is an anterior segment OCT view showing you that cleft, highlighted here by the arrows where trabecular meshwork has been removed. What's unique about this blade, again, is because we're removing this tissue, now we have the ability to study it. And this is something that's really exciting, something that could hold promise in improving our knowledge base on what exactly is going on at this tissue level in glaucoma. So moving on to outcomes, first preclinically we studied this in human donor perfused eyes where the angle was treated with either an MVR blade trabectome or with the dual blade. From the far left with the MVR blade, you could see a nice incision through TM, but no removal of that tissue and actually collateral damage to the back wall of the canal. With the trabectome, you had a much more complete removal of that trabecular meshwork tissue without collateral damage. There was some coagulative damage on those trabecular meshwork leaflets that were left behind. But what we found with the Kahook dual blade, we had the most complete removal of the tissue. Now, moving on to clinical outcomes, this is data from a multi-center trial from 8 surgeons in their first 10 to 20 cases with the Kahook dual blade, looking primarily at IOP, medications, and complications, or figuring out the adverse events that occur after this, and also surveyed surgeons' intraoperative experience with the Kahook dual blade. Most commonly represented group was POAG patients, about 70%. There was 13% of angle closure and a handful of pseudoexfoliative or pigmentary patients. And a fairly even smattering between mild, moderate, and severe disease, but actually the most commonly represented group was the severe category, like 41% of patients, so it's important to keep that in mind. Procedure type most commonly performed was in conjunction with cataract surgery, or phaco KDB, about 60% of the cases in this study, but this was left up to surgeon discretion, so some were paired with ECP, some were with ECP phaco, some standalone. But in all cases, in 93%, trabecular meshwork was able to be removed from the anterior chamber after the procedure. The average extent removed was 114 degrees, or about 4 clock hours. Looking first at the feedback from surgeons, this was largely positive. In over 98% of the cases, surgeons either agreed or strongly agreed that, number one, the overall use of the blade was straightforward, number two, the entry into the canal was uncomplicated, and that the advancement within the canal was smooth. And so these are the results that we've seen so far. We now have data out to 9 months. You can see from a pre-op level of 18.7 millimeters of mercury on 1.8 medications. These are all eyes to date. Falling down to 12.9, or about a 6-point drop in IOP. In addition to that, you're getting a reduction of medication use on average by about 1 medication. But focusing in on that phaco plus KDB cohort, since this was the majority of the cases, and this is where I think the blade is primarily being used in clinical practice today, you can see very similar results. So mean IOP falling from 17.4 to 12.4 now to 9 months, or a 5-point drop. In addition, you're also reducing medication burden on average by 1 medication. And you can see the results being fairly consistent. This is illustrated here in this graph. What's most exciting for me with looking at this data is that we're not starting from a very high IOP. So the pre-op IOP medicated was only 17.4. We know with any glaucoma treatment, the higher your pre-op IOP, the more likely you are to see a greater reduction. But when we're starting from a mid-teen IOP of 17.4, it's very difficult to get down to that 12, 13 level consistently without doing some type of filtration surgery. So to see this magnitude of drop starting from a relatively physiologic IOP is very exciting for me. And then also medication use, you can see falling from 1.6 to 0.6. Looking at adverse events, not surprisingly, as with any angle surgery, hyphema is going to be your most common adverse event. And this was no different here. Intraoperatively, this was noted in 40% of cases. But what was a bit surprising is that 1 day post-op visit, the hyphema rate was only 9% in this study. This fell to 3% by a week, and only 1 patient had that persist beyond a week. When you compare this to other angle-based surgeries, this is published data, trabectome hyphema rate at 1 day is 78%. With the gap procedure, even at 1 week, there was still a 30% hyphema present. The second most common being IOP spikes, most commonly appearing around that 1 week to 1 month visit. There were 2 patients who required additional glaucoma surgery for uncontrolled pressure, but all other complications were rare or considered minor. So in summary, with the Kahook dual blade, we've seen clinically meaningful pressure reduction. Looking at all eyes, about a 31% reduction in IOP. Almost better results pairing it simply with phaco, where you have a 34% reduction, again starting from 17.4 down to 12.4, now out to 9 months. In addition, you're able to reduce that medication burden for patients. On average, patients are getting off 1 medication. A little over half were actually medication free after the procedure, and all with a very good safety profile, hyphema and pressure spike being the most common. So just looking forward, we obviously need longer term outcomes. 9-month data is great, but we don't need a 9-month procedure. We need this to stay consistent beyond this, so we need to follow these patients out to see how they do long term. Subgroup analysis, I think, may help identify who are the best candidates, who are the best responders to this procedure, and maybe some who were not, so we can better tailor our therapy. I'm particularly interested in combining this procedure with an inflow procedure like ECP to see if we can get some additional IOP lowering. So far, preliminary, what we've looked at in Colorado is that there's really not a lot of additional benefit in adding ECP. The dual blade is giving you most of the effect. And comparing it also with other angle procedures to see not only which works better, but in which particular patients each procedure is best suited. Thank you very much.